네, 감사합니다.
No, this is P and P. Yeah. Yeah.
I don't think if it is really P, it is not AB dissociation. You point to P every down wave onset. So there,
There is no visible P wave and atrial pacing. We just see in the right quartz complex preceded by ventricular paced rhythm. And then,
speak louder.
8 feet of non-sustained VT, 8 feet of short duration of non-sustained VT, just 8 beats. Maybe patients have only BVI, or if it's a dual chamber, maybe patient has atrial fibrillation.
I don't see any
Mm.
P wave. So,
This is
yeah, looks like,
wave.
but I'm not sure. And what is the baseline rhythm? Not the tachycardia rhythm.
Baseline rhythm.
It's pace rhythm, right?
Mhm.
And which point is unusual? Is it standard 12 lead ECG or telemetry?
Maybe not standard EKG.
It is a standard EKG. But how do you display all 6 leads? Is it Philips telemetry?
So at the
Is it outside patient rhythm or?
inside the patient's rhythm. Maybe
Our telemetry doesn't show the all precordial lead, only B1 and B5.
yeah, right. So I was actually wonder why how can this patient get all the EKG?
심전도 실장님.
여기서 심전도 실장.
이게 스탠다드 EKG였잖아요. 외부에서 본 거.
이게 뭐 스캔된 거를 가져온 거예요? 아니면 뭐?
EMR에 EKG라고 해서 스캔이 올라와 있긴 했었거든요. 저희 그 위주에서는 그런 건 아니야.
Outside hospital EKG?
근데 그건 저도 되게 사실 확실하지 않은데 진료래 뭐 의무기록사본 이런 데서 가져온 거
CCU?
네, CCU입니다.
CCU는 가능하지. Philips telemetry display all precordial leads. So we cannot trust the exact lead location if it is telemetry, right? But the unusual finding is if it is usual the permanent pacemaker implantation, usually we pace the mid-septum or not very far apex. But if you look at the B5-6, all D-best wave means B pacing is undergoing very far apical RB apex, right? And look at the lead one. It is S wave predominant, right? So usually, if it is a right ventricle pacing, usual pacing side is V1 lead one positive, but it is from left to right direction, right? So pacing side is unusual. So I assume that it can be potentially the temporary pacing status. And also, what is this? First morphology is different to this guy and this guy, right? Probably BT already initiated from here. It might be fusion bit with paced rhythm and BT. Okay. Oh, not BT, wide cross complex. Probably that's why Dr. Joe brought this ECG. And Georgia point is it could be the dissociated P wave, but it is short period, and I cannot see any P wave in other ECG. So I don't know, this patient, the baseline atrial rhythm is atrial fibrillation status or the real, the hidden, very small P wave. But the probability of BT might be higher. And Dr. Lee, any further comments?
I think also you find the evidence of positioning more evidence of VT. The case of VT direction is the opposite of the pacing size. Which is might be helpful trend. Also, we doesn't have a or 12 readers.
Okay. So any other comments? Dr. Joe? Professor Kim? This looks like small P wave. Yeah, but because this is telemetry ECG, I cannot clearly define the P wave. But as Georgia mentioned, this guy and this guy is a little different. And if you see the some notching on P wave contour, it could be the overlap P wave. Okay. If there's no further comments, okay. Next slide.
This patient, male and 52-year-old, his complaint was syncope. They occurred dyspnea and palpitation for 1 month. Symptom was aggravated for 3 days. Syncope for 1 minute, and when he just standing at parking lot.
What does it mean? 1/26.
It's been January 26. His vital sign was not bad. His medical history is dialysis cardiomyopathy with heart rate and with a CRTD. He was in permanent atrial fibrillation on block and hypothyroidism. His medication was apixaban, atrostan, bisoprolol, and so on like that. Initial lab finding was not specific, just troponin T elevation and NT-proBNP was elevated. This is the initial EKG. There's wide QRS with pacing, sometimes with the PVC.
Okay. So I would like to ask Professor Kim interpret this CLTD ECG compared with previous telemetry.
very similar. And we can find very similar PBC.
Beautiful. And that
data. 그다음에
내가 밀고 있.
So this, yeah, this is maybe PBC or fusion bit very similar with previous ECG. IV pacing, but maybe LV lead is a little bit powered mid to apex, so we can see negative polarity in V6. So I think it is not that optimal position. I mean, LV lead and a little bit inferiorly, yeah, located LV lead because we can see all negative polarity in V2, V3, AVF. So I think it may be in posterior branch or maybe in MTB, so
MTB,
MCV,
MCB.
maybe. So I think it is not ideal position, and heart rate is a little bit fast. Yeah, it's usual setting in patient with AFib and who undergoing AV junctional ablation, maybe 75 beat per minute or 80 beat per minute, maybe. But we can find still PVC and non-sustained VT, so we can guess that patient condition is not that good. And we already know that patient was in CCU.
So, Professor Kemp, could you please explain what is the optimal ECG finding after CRTD?
Optimal finding,
Mm.
yeah.
So, in my limited experience, this ECG is not very ideal. The VPCing ECG after CRTD. So, what is the acceptable and what is the ideal ECG after
Yeah,
CRTD?
V1 RBBB pattern is quite good finding, but more important lead is lead 1 and AVL, which means the LV lateral wall. So in lead 1 or AVL, negative polarity and a little bit fast, negative deflection time means the LV lead is positioned in appropriate position. Other thing is, it is not mandatory, but in V6, if the polarity is positive, then it means the LV lead is positioned in basal part. And usually LV lead position is recommended in non-apical position and basal or at least mid position. So the negative polarity in V6 is not that bad, but it is not that good.
And the QRS width is less than 120?
But it varies according to the patient, underlying conduction property and heart size and native QRS duration. So I think all QRS morphology shows that the patient condition and heart condition is very, very poor. So there is no absolute cutoff value, and I think patient condition is not that good, right?
Yeah, very
And also BT.
Yeah.
So the fellows should recognize only every arrhythmia with structural disease is on top of their structural heart disease aggravation state. Okay. So if the ICD stable ICD implanted heart failure patient got the ICD storm all of a sudden, you should check whether this heart failure condition is aggravated. Okay. So always think about the aggravating factor and the underlying disease. So nowadays the CSP conduction system pacing is very popular, and I saw quite often to see the very narrow QRS paced B after CSP, but after CRTD, come on. Even though the QRS width is narrower than before the procedure, but still the CRTD is class 1 indication for HFrEF, but CSP is class 2A indication So I would like to have your thoughts about the future.
Yeah,
Future of the
we,
device.
we need more ICT
I know,
comparing,
yeah.
CSP and BCRT and if the CSP success rate is not 100%, and it goes down when patient condition and heart condition is poor, then the CSP success rate and QRS duration is not that good. So we need RCT, and in this last ESC meeting, there was some RCT comparing CSP and BCRT in patient with LBBB, and the result was BCRT was superior compared to CSP. So
It was done in Brazil.
yeah, right. So I think that in patient with LBBB, which is class 1 indication, for BCRT, and I think that BCRT is still the answer in patient with LBB, but we don't know in patient with AFib and in patient with non-LBBB. We don't have the best answer because BCRT's response is not that good in that kind of patient. I think CSP will have some role in that kind of patient.
Okay. So the current data, limited data, and retrospective studies favors the CSP. It is because the patient population has been different. The CRTD patient is a more bad condition, significant heart disease, and the CSP is mild heart failure. So that is the Professor Kim's thoughts. And especially in patients with septal scar and fibrosis, CSP doesn't work. So is MRI is mandatory before CSP in patient with heart failure?
Yeah, it is helpful, and usually MRI is mandatory in patient with HAP-lab. Yeah, even though the patient has no plan to have CRT, MRI should be taken in all heart failure patients. So it is useful and helpful before CRT implantation.
Okay, one last question. I'm not interrogating you, but how do you think about the CRT defibrillator in patient with dilated cardiomyopathy?
I mean, non-ischemic, right?
Non-ischemic cardiomyopathy. This patient is non-ischemic, right? Yeah.
Yeah, actually, in the past, it was not that difficult to answer because when we implant CRT, just adding CRT-D is not that hard, very easy, and there was no reason to select CRT-P. Yeah, but in CSP era, it is quite difficult question. Yeah, because when we choose CRT-P, we have more option. I mean, LOT CRT. But if we choose CRT-D and we use DF4 lead, which is usually used in CRT-D, then we should select whether we use the LBBP lead or conventional LV lead. And if we want D and LOT CRT, then we should use DF1 lead, but it is, actually MRI compatible, but it is not on-label the MRI compatible. So we don't have the exact answer and we need more data.
Actually, world changes very quickly, especially part of CID heart. So all the EP doctors, including me, should study harder and learning more And the foreign fellows requested some, they need the train for the programmer, the management. So I asked the company after the EP procedure, somebody will come to you and teach you give you the opportunity to simulate with the program. Okay. 그 이준영 만나러 그랬어.
목요일로.
했어 벌써. Okay. Let's go ahead.
This is the initial chest X-ray, and you can see the severe cardiomyopathy and implanted CRTD. This is the initial TTE. It was severe global hypokinesia, and reduced LV systolic function and LV systolic function, and enlarged the chamber size. After CRTD interrogation, we saw the total 99 times VT and after 1 times ATP, it was all terminated. So we managed the VT, amiodarone, and bisoprolol, propranolol, and finally we got the stellate ganglion block. And we considered the VT ablation, but after amiodarone confusion, it was stable. After that, actually he was a severe rep, so in Campart, they consider LVAD implantation for waiting heart transplantation. After LVAD implantation, there was no more VT. This is the final EKG, no more VT and no more PVC.
Okay, so let's discuss about the decision making. At this point, patient experience many ICD therapies. No shock, right?
Yeah,
ATP work.
Initially,
ATP
no
work.
shock.
Okay.
Yeah.
Yeah.
Actually, for 3 days ago, he come to
Mm.
manual VT and shock event, but at that time there's no shock.
So there are several choices. Number 1, amiodarone and antiarrhythmic drug therapy. Number 2, catheter ablation. Number 3, LVAD like this. Number 4, heart transplantation. So how do you make decision? Dr. Joe, this is your patient.
This patient
크게 얘기해 주세요. Speak lightly.
patient I think more worse prognosis or higher patient date. It should have LVAD already.
LVAD earlier. It's very, very expensive. And they're requiring the open chest surgery.
Yeah,
Right.
but
Yeah, the designated therapy should be heart transplantation. But the cardiac surgeon, transplant surgeons doesn't like using the amiodarone. There's a report the patient who used the amiodarone long term, the transplantation outcome is bad for and many more complications. So okay, so based on the Vanish 2 criteria, antiarrhythmic drug should be first. But the Vanish 1 is the antiarrhythmic drug, and comparing the catheter ablation versus the increasing dosage of antiarrhythmic drug. But the recent studies, Vanish 2 and Partita favors primary BT ablation if the patient experience ICD therapy. So either way is okay. So Dr. Park, how do you decide? Drop or ablation? Ischemic? Non-ischemic. First time shot. No shot. 99 times of ATP. Where were you? First, managed to is patients with ischemic VT. And 35 more patients who underwent first time ATP or shot. 2 sick patients might be more appropriate. for, uh, 10 parts about decision flow. Based on those trials, the population should be considered first. But if two adults not failed or too many prior shots, skip that and about 40 appropriate with this in mind. So I think either way is okay. The amiodarone or catheter ablation, because the ejection fraction was 35, 33.
Lower than,
32.
Yeah,
actually change, seriously changed, but at that time 33.
Yeah,
But initial, another PT, there was a 20% to 30%.
so for me, if it is not completely decompensated heart failure and there's chance to be recovered, I can recommend catheter ablation. Unless this VT morphology changing, multifocal VT, too many ablation worsen the heart failure. So if it is localized VT, you can recommend the VT ablation. But the most important one is shared decision making. So heart failure team, EP team, and the transplantation coordinator all come together and discuss about the future prognosis of this patient. That is more important. How do you think, Dr.
I miss the first part of this presentation. However, the VT ablation in non-ischemic cardiomyopathy is not easy, and many times we repeated the procedure.
You do every day.
Yeah, are required. So it is very sophisticated decision making. So, at first, the patient condition and VT morphology and how many morphology of VT should be considered.
Yeah.
In addition, in patients with LVAD, VT ablation is very difficult because a lot of noises from LVAD. So we may miss many small fragmented potential because of noise, LVAD noise.
I guess heart failure team decide the LVAD to bridge the transplantation because this patient has the poor valve function.
Right, it is a bridge strategy, but actually I think because the regional decision about is heart failure aggravation. For months to 2 months, they managed the GDMT with diuretics, but pulmonary edema and AKI recurrently. Yeah, so they finally decide,
If the patient condition is more than near class 3 heart failure,
yeah, almost,
I think heart failure management should be first.
yeah.
If you really want to ablate the VT, please check the PANST score. You know what is PANST score. If pain score over 17, the mortality is about 30%. So you have to be very careful and try to avoid those high risk patients unless it is ICD stall. Okay. Okay. Any other slide?
No.
Okay.
Yeah, I
Yes.
have a question
Yes, sure.
for the LBBB MRI.
What is the LBB MRI?
그
Patient with LVVB can, perform MRI.
MRI 그러니까
한국말로 해, 한국말로.
그러니까 LBB 하면
They can understand Korean.
예를 들어서 MRI 찍어서 세탈 스카가 있다고 쳐보면 LBB 하면은 되게 반응이 안 좋을 거다라는 거에 포인트가
LBB가 뭐야? 아까 CSP 얘기한 거?
예. 그게 그러니까 해보고 결론적으로 모포로지가 안 나오면 바로 DCRT로 가는 건데 MRI를 약간 찍어서 여기 세탈 스코어가 많으니까 LBB는 안 해야겠다라는 포인트가 어디 있는 건지 그러니까 그래서 결국 필요하다기보다는 해보고 안 나오면 에러 DCRT로 간다고 생각하는 사실 저는 그렇게 생각하고 해오긴 했거든요. 근데 필요한가
아니 근데 septal 스카가 그냥 서프트라거나 그냥 메조카디알 이런 거면 we don't have to worry about CSP, but if the septal scar is very huge in extent, and still we have very usual answer by BCRTD. So if the septal scar is very huge, then we can implant by BCRTD, then there is no reason to select CSP. Just go to by BCRTD. But the patient electrical dyssynchrony is very severe, and if the intraventricular conduction delay is very long. So if you think that the patient it will be the LOTCIT will be beneficial to patient, then you can try CSP first, unless the septal scar is not that huge. But just presence of septal scar, there is not that big deal.
Another point is if the patient has frequent PVC from the basal septum, you will burn the CSP point, so it's better to avoid. And inflammatory cardiomyopathy, for example, sarcoidosis. Sarcoidosis start from the high septum, so the progress is conduction disease first, then VT, and eventually heart failure. So it is progressive disease. In those patients, if the sarcoidosis patient shows an extensive septal scar, it's better to avoid the CSP. Okay, thank you very much. Recording off, and let's move to